Well, welcome everybody. We are very honored here. Let me fix my mood lighting here. There we go. Now you can see my face a little better. Welcome to our webinar tonight. I think this is at the moment my annual or my last one of my presidency here of these. We started these fireside chats shortly after COVID started. And that was back May, June, something like that. And we thought we would cap this one off. This one, I actually had the idea of doing this one back when we started coming up with ideas for these webinars, but we didn't want to bother Dr. Tannehill because at the time he was knee deep in COVID. And we needed him in the ICU more than we needed him here on a webinar. So I definitely want to welcome all of you tonight to our COVID-19 A Year in Review, as we called it. With our special guest, Dr. David Tannehill. Here you have my bio, which you can quickly screenshot and then look at it later if you really want to look at it. But I'm not going to read it year for year or word for word, sorry. And then we also have Dr. Tannehill's bio there. You got the picture with the beard in there, so that's good. So this really is a part of your new look. So that's awesome. We are grateful to have him here. He is the clinical director of critical care medicine for Mercy Clinic in St. Louis, Missouri. He is a past president of MAOPS. These are all wonderful things, but most of all, I think tonight is that he has been on our front lines of treating COVID for the last year. And that's why we have him here tonight, is to be able to discuss with him his experiences, both as a physician leader and then obviously as a physician practitioner, somebody who has been practicing medicine. So we're really excited for his input tonight. This is our disclosure slide showing that neither of us have any financial or relevant disclosures to disclose. And then these are our objectives for tonight. We would like to describe some of the early experiences in COVID during COVID-19 in the ICU and hurdles that were needed to be overcome. Talk about why we as physician educators are important to be working with our patients and setting an example, and also in educating them on the need for masks, understanding why we're doing these lockdowns and why vaccines are important, and then also understand future ways that COVID might affect us in our practices. I think this is the biggest thing on everyone's mind. How long are we going to be in lockdown? How long is COVID going to be around? Has it gotten rid of flu? Is it a new flu? I mean, these are the questions we deal with on a daily basis right now. So with that, I'm going to stop my screen sharing, and then we're going to begin this discussion. Now, for those of you that are on this discussion with us, and welcome to all of you, please feel free to interrupt. You can type or you can raise your hands. I'll try to keep an eye on the hand raising and things like that, and we will do our best to include you in this discussion. I think we do have the ability to add you, so if you want to ask some questions while we're going, we are perfectly fine with doing that during this. But I guess I'd start with just say welcome, Dr. Tannehill. Thank you so much for being here.
Happy to be here. Thank you.
Perfect. Well, hey, how are things? Just today. What's your life like today going on right now? We call this COVID year in review. I know that COVID numbers are down across the state. I can see the numbers. They are significantly down at my hospital. In fact, I was amazed today because I looked it up and we only had 32 patients in the hospital this morning, which when we were at 190 just a month ago, to see that number 30 to me is almost a miracle. How are things going on your end of the state over there in St. Louis?
Yeah, so it's almost getting back to normal. Just the other day, I guess it was about a week ago or so. So part of my role, I'm responsible for the ICUs across all of Mercy Clinic, and I get this report every day of how many ventilators are in use. And across all of Mercy Clinic, we had more than 200 ventilators in use for months and months and months. And then finally last week, we finally dropped under 200. Usually in normal times in the winter, even in the winter time, even in a bad flu season, maybe we would have 150 vents, maybe. And so it's really starting to get back to normal. In fact, the first couple of days this week, I didn't have any COVID patients in my ICU. Today I got two, but until today, I didn't have any, and that's the first time it's been that way in a long time.
That's awesome. That's so good to hear. You know, we're the same kind of way over here, at least from the outpatient side of things. I've tested maybe only 3 or 4 people even wanting testing in the
Yeah,
last week, and none of them have come back positive.
yeah,
And for me, as an outpatient provider, you know, we see community illness going through. I've got some kind of cold going around here that's not flu and it's not COVID because it's not testing positive. And I don't think I've ever been happier for a cold to be going through my community. A
yeah,
non-COVID cold, at least as far as we can tell. So,
right.
so that to me tells me, you know, if there's anything that's telling me we're returning to normal, it's the fact that we're getting other illnesses
Yeah.
besides COVID.
Yeah,
Which,
and it's been really weird not having any influenza. I think I've had 2 influenza patients the whole flu season. It's just non-existent this year.
and do you feel like, you know, and I'm sure a lot of people on this call would ask the same question. We know that the flu test has a decent false positive rate. Do we even know if that actually was influenza? Do we lab verify, or was it just sort of rapid tests? You know, I'm just
Yeah,
curious about that. You
yeah,
know, who,
yeah.
who knows?
I don't know.
So who knows if it really is? No, I agree with you. So I stopped doing flu tests quite a while ago after I'd wasted, a dozen of them being negative.
Right.
You know, it was like I looked at the expiration date on the box and said, "Hey, these are good through next year." So
Yeah. Hang on to them, right?
we'll hang on to those. And when these new illnesses started coming, we started using them again, just to see, is this influenza maybe finally, because it wasn't coming back positive for COVID, but it's not coming back for either.
Yeah.
Which is interesting. So let's circle back to that. You kind of hinted at, you guys were having at a time 200 people on vents, but normally you only have 150. Did you have those vents available, or were those things that you guys had to seek out, buy new ones, or?
Yeah. So in the beginning of the pandemic, there was a lot of anxiety about, are we going to have enough? Sorry. In the beginning of the pandemic, we had a lot of concerns about, are we going to have enough ventilators, BiPAPs, high flow oxygen devices, that sort of thing.
It was all over the media.
Yeah, and one of the interesting things was we didn't even know how many we had. Each individual hospital might have had an idea, but the whole Mercy Clinic, really didn't have any visibility around, what do we have available, what's in use, and that sort of thing. And a lot of the work that I was involved in the beginning of the pandemic was just kind of getting our ducks in a row of what stuff do we have, where can we put patients, how many ICU beds do we have, that sort of thing, because we didn't really have an organized way of looking at it from a system standpoint. And so we spent a lot of time trying to figure out where we were at. And it was really just hand counting. We didn't even have it like on a computer program. And so spent a lot of time trying to work through that and try to figure out, how do we have that information immediately available in a dashboard, in a data presentation type format, so that we could have a better handle on real time or near real time situation.
I think all of us hospitals and health systems, wherever we were, kind of went through this growing pains. I agree with you. It was like, I mean, in our case, it was, how many boxes of gloves do we have
Right.
in the clinic?
Exactly.
How many masks do we have?
Yeah. We have a system for counting how many gowns we have, that sort of thing.
Right. I remember very clearly, they came to us one day and took all my face masks away, except for a few, and gave them to the hospital, to you and your specialty, which, I'll be honest, I was very happy to do. We weren't even seeing patients then. They were all scared at home. So, it wasn't like we were needing them as much, and we were doing so much telemedicine. But yeah, it was there. Was there a point early in this pandemic where you guys were critically low? You didn't know how many masks were going to be there the next day?
Yeah, it really was. I mean, I remember in working with like our supply chain folks, we were literally down to a day and a half's worth of PPE is all we had left, and we were waiting for shipments to come in, and there was one time we thought we were going to have a huge shipment come in, and our shipment was commandeered by the U.S. government at the border, because they were working on getting equipment, PPE and stuff, to areas that had a higher incidence, more cases to deal with and that sort of thing. And so we actually lost a couple of shipments because of that sort of process. But yeah, it was pretty hairy there for a while. And what was compounding it was people were panicked because we didn't really know mode of transmission. We didn't really know how infective the virus was. And so there were a lot of people that were using PPE that guys like me working in the ICU didn't think they really needed to be using what they were using as much as they were using, because they didn't have the risks that we have in the ICU. And so trying to navigate, what do we have available, who's using what and how, who should be using what even are the types of things that we should be doing. It was working through all of that was just crazy.
When was it, going back a little further, when was it that you first started? I have a feeling you probably went through the same thing that all of us did last December, maybe November, December. In the back news story, there was this virus going around China. Mm-hmm. And if you were like me, they talked about coronavirus, and I just pulled up everything I knew about it from med school, which was list of most common colds, adenovirus, coronavirus. I mean, that was it. That's all we knew about coronavirus. And so for me, it was just like, okay, China's got a new cold going around. I mean, I fully admit that to my patients. I didn't take it seriously when it was first going around. When did you first start taking it seriously or realizing that this is something serious? Because I know St. Louis had some early waves that we did not have here on the west side of the state. Do you remember that or remember that transition? What was it that really made you say, whoa, this is different?
So in December and January, when this first started to pop up in China, I paid attention to it, but it was more like this. It was this novelty that I was paying attention to. Over the course of my career, when I was in fellowship, was during the H1N1 outbreak. I remember SARS and MERS, whenever those were in the media and people were talking about that. I don't think I viewed it as another cold virus or whatever, because when the original SARS that came through and when it hit Toronto, that became pretty scary. Knew that was a coronavirus and that sort of thing. But I really I figured that we would have the appropriate infrastructure and processes in place to keep the epidemic contained. China and the U.S. government and everything would do the things that need to be done to keep it contained. Once it became clear that that was not going to happen, and the first outbreak was in Seattle, that really caught my attention. When it showed up in Seattle, that's when I kind of perked up and was like, this might be really bad. And it was the beginning of February last year that Mercy started having some meetings that kind of talk about, what do we need to do? How do we need to talk about this in case this gets bad? And I remember getting the first email and invitation to the first meeting. And I thought to myself, this will be good practice in case this ever really does happen. You know what I mean?
Yeah.
And at the first meeting, there really wasn't much sense of urgency. It was just, how do we even think about such a thing? Let's talk about the basics of managing this sort of deal. What lessons did we learn from H1N1? And in 2013, there was a really bad influenza outbreak in Missouri. Most of the country was okay, but Missouri had a really bad influenza outbreak in 2013. And then as the month wore on, I really started to almost panic, because it really looked like this really is going to happen. This is going to be really bad. And I actually, Mercy's chief quality officer, it was after one of our meetings, I called Mercy's chief quality officer and I said, I'm not hearing enough of a sense of urgency for the inpatient setting. Would it be okay with you if I just sort of took the bull by the horns and got us ready for this? And he said, and he I'll never forget it. I could hear this like sigh, and he was like, you know what, we need to do that. He was like, we're not going to be able to pay enough attention to all the different pieces. He was like, go for it. And so then I knew I had to really roll up my sleeves and dig in. And I met with all the ICU directors, some of the infection control people for all the different hospitals across Mercy Clinic. And we got to work trying to figure out, what do we have? What do we need? Where can we put patients? That sort of thing. In parallel, Mercy was working with our data scientists and some people to try to figure out, how can we get a handle on, can we predict what's going to be coming? At the time we couldn't even test really, we
Right.
didn't really have much to test. And so it was just looking at who's in the hospital on oxygen, who's in the hospital on BiPAP, and trying to figure all that stuff out. Once we were able to get some real, get our arms around the data so that we knew how many cases we had and what was going on in the community and how many cases may come, and we could get some real projections. It was starting to look like the end of March and the beginning of April was going to be true nightmare scenario type stuff. And so then just working through, how do we take care of these patients? What are the logistics for all this gear and people and everything else? And then one of my buddies called me and he said, what about crisis standards of care? And it was like, oh, now we got to go through that. So it was just, every day there was just a new bunch of stuff that we had to do and new questions to go over. And it was hard to go to sleep, hard to fall asleep at night.
And I think we all, we kind of went through that, and each of us in different stages. Of course, you being in the ICU, you saw these things quicker than we did, because that's where sick people end up, the fastest. But we went through that same thing in the outpatient setting, where we started seeing more and more news, more and more of this, and and that's how I went through too, from this vague virus in China to this might be something serious. And for me, it was, I had a planned vacation mid-February with my family, and we went to Disneyland. We actually were there 2 weeks before Disneyland closed. And it's still not open since then, by the way. And
Yeah.
and when we were flying in and out of LAX, especially when we were flying out of LAX, I noticed all these foreign travelers, and they were all wearing masks.
Yeah.
And I was like, well, I was kind of like, is that overkill, or is there something going on here? And I knew they did that a lot, but it wasn't just one or two foreign travelers. It was a lot of foreign travelers wearing masks. And so I got back and I went to my administration and said, hey, maybe we should take this a little more serious. It was our clinic administration, not the whole hospital. And my response to that was, we don't make decisions based on media reports. And so, and I don't fault them for that. They were in the same state of mind that I was a few weeks prior to that, and I was slowly shifting. And then 2 weeks later, they were where I was, and then we were making some serious decisions. So, and that's how it is. And so it's all, how did you deal with that? Because, and Brian, mentions this in the chat as well. You were an early advocate for lockdowns when a lot of times the rest of us were still trying to come to grips that this was a virus that was going to need to be taken serious. Can you tell us a bit more about that experience? Because I know that was a very, very rough time for you. You were treating people on ventilators and watching your ICU numbers go up, whereas physicians, even other physicians like myself, were just watching our clinic volumes go from 25 patients a day to zero.
Yep.
Because of these lockdowns and things going on. How did you deal with that? Can you tell me more about that experience? Because your perspective is extremely unique.
Yeah. So, as everybody knows, the first cases were in the St. Louis area, and the, first real kind of explosion of cases was in the St. Louis area. And, we were seeing these patients that were in the ICU, and they were just so incredibly sick. And there was this recognition that, not everybody's seeing what I'm seeing, and, and so trying to make sure that I remember that, not everybody's seeing what I'm seeing. It's not tangible to them. It's going to seem distant. So how do I communicate what it is that I'm seeing and how sick these people are? And, normally in the ICU, especially, we know what we're dealing with, we know what we're diagnosing, we know how to treat it and that sort of thing. There were so many unknowns in March, it made it that much scarier. And so, we were watching otherwise young, pretty healthy people that were getting incredibly sick, not to mention those that were chronically pretty ill, and just trying to communicate that. And you basically just had to rely on the emotionality of, listen, there's a guy in my ICU he's just like you. He doesn't really have a whole lot of health problems. He's your age. He's got young kids, and he's going to die. And just having to rely on those sorts of anecdotes is all you had to rely on, which is kind of challenging. That's not really how I normally think. Normally, it's very data driven, and it's focused on what the real risk is and that sort of thing. And since we didn't really know a lot of the answers like we needed, we were assuming it was airborne transmission. We were assuming that you needed this, that, and the other thing for PPE, not really knowing what the definitive right answer was, but knowing that doing nothing was the wrong thing to do just made it really hard.
And, as we were advocating for these lockdowns, can you describe some of the resistance and maybe the thoughts that were going through your head when, maybe even your own peers or colleagues were saying, man, this is Missouri, we don't need to lock down?
Yeah.
And
like
there's some that are still that way.
Yeah. Yeah. And I get it. I understand why people may resist a little bit. And I can understand the argument that, we didn't have great data to guide us on what's the right thing to do. And it really was kind of this, you're sort of assuming that these different pieces of information fit together to where the right thing to do is to shut down and wear masks and socially distance and that sort of thing. There was an element of just kind of taking it on faith that, listen, I'm telling you this is the right thing to do. I'm looking at the numbers. There's going to be a lot of cases and people get really sick. Nobody's seeing it. As an example, I had a buddy of mine that he called me just to check in and say, hey, how are things going? And he said, I don't get it. He's like, I don't know anybody that's been sick. I don't know anybody that's been hospitalized. I don't even know anybody that's been tested or diagnosed. Is this really a big deal? And I said, yes, it's really a big deal. My ICU is overrun with patients that are really sick like this, and we're running around trying to count ventilators. It really is a big deal. That's all I was left with. That's all I could do is just sort of rely on people just trusting me that what I was seeing really was scary. Made it really hard. It made it really hard. Once we were able to actually test and people were reporting on positive tests, it started to become an easier conversation.
It's absolutely the experience that we went through, and masks are another example early on, and that was even harder because here we were at the beginning of the pandemic telling everyone, don't wear masks, don't wear masks, don't wear masks. I mean, I put Facebook posts on it, and I, primarily it was because we needed the mask for you. I mean, as I said before, I was even giving up my own clinic's masks so that I could make sure my ICU doctors had masks. And then suddenly it was wear masks, wear masks, wear masks, wear masks. Right. And patients struggle with that. Yeah. They struggle with the fact that medicine can be wrong. And, we accept that. We know that. It happens all the time. But, I think there is an implied, sense for a lot of our patients that, whatever problem they have, even an unknown one in the future, when I bring it to my doctor, they will know the answer to it. And the COVID pandemic pointed out to a lot of individuals something that we knew, but they didn't necessarily grasp, and that was we don't have as much control as you think we do.
Yeah, and to add to that, we don't have as much control as you think we do, and we don't necessarily have all the right answers all the time. but we would change the answer 3 times in a week, and I remember one time in a meeting saying, we were talking about how we're going to manage some PPE stuff and that sort of thing. And I remember in a meeting saying, you know what, we don't know. Okay, so let's just not change anything for 3 days. Just leave it alone and just let's see how things settle and figure out some more answers, because so many people were working in so many different directions, and you get mixed messages, and people are reading something on social media that's contrary to what we're telling them. And we don't have hard evidence, and people are publishing stuff. Like, I've never changed my practice because of a social media post before until COVID. And then you would read a social media post and you'd say, oh, you know what? That sounds right. We should probably do that in our practice. It's crazy. It's crazy. If you back up 2 or 3 years and somebody told me that I was going to do something different in how I take care of patients because of something I read on Facebook, I would have said, you're out of your mind. But we did that routinely last spring because we had nowhere else to go.
There was no answers available.
Some guy in New Orleans and what his experience was like, and we went with that. It was nuts.
It reminds me of that evidence-based pyramid, and at the very bottom, the least level of evidence is, what is it, peer peer recommendation kind of thing. The very
Right.
bottom. But with COVID, what our patients didn't realize is we didn't have the meta-analysis. Peer recommendation was the best evidence we had available, those first few months. And it's sad, but it's true.
Right.
You never thought that we'd have to go to that. And the way I've always explained it to my patients is, you realize that every other disease before COVID that I have been treating you with, I'm dealing with 20 plus years of information, data, safety information. And we figured out that these medicines were safe and they worked because we used them so long that we knew they had to work because we had so much evidence. And on COVID, I've only known about this for about a month, and we're just guessing. And
Yeah.
I still tell my patients to this day, 5 years from now, we're going to learn that everything we've done this last year was wrong. So,
Oh yeah,
I say the least ideal, a lesser ideal option.
at the end of March, it was routine to be treating people with Zithromax and hydroxychloroquine.
Correct.
Everybody was convinced that's the right thing to do.
And some are still.
And what?
And some are still convinced.
Yeah, right. And I remember having conversations with some of my colleagues and just saying, do we really know this works? I mean, are we sure this is the right thing to do? And the EMR is telling you to watch out for QT prolongation, and you're getting nervous because you've got this person on hydroxychloroquine and Zithromax, and then they're on amiodarone because of their atrial fibrillation, and you're just watching the EKG and watching QTCs of 600 and thinking, this is crazy. Something about this doesn't sound right. But we didn't have anything else. And just the compulsion to do something caused us to do a lot of stuff that may have actually hurt patients, and that's one of the real lessons that I've taken from the pandemic, is that compulsion to do something comes from a good place, but keeping that controlled, to remember first do no harm, has to trump that compulsion to do something. And we kind of threw that out last spring. We just sort of said, all that stuff that we've told ourselves about evidence-based medicine, let's throw it out the window because we want to do something for these patients. And that was a mistake. And really sticking to those evidence-based medicine principles is I've always felt strongly about that in my practice. And the pandemic did nothing but reinforce that.
For me, evidence-based medicine, and I'm sure it was for you. I mean, you're not as old of a doctor as you pretend to be, but you were probably strongly, hit with evidence-based medicine practices in your medical school training, as was I. And for me, it was startling to watch how quickly some of my colleagues would just throw that out the window. And it's, we have, even if we were applying historical data, we have great historical data that antibiotics don't do anything for viral infections. And then suddenly I had people, watching people tout, antibiotics for what we were pretty sure was a viral infection. Who
Right.
knows? And I don't fault people in the beginning for wanting to find something to do something. Where I struggle more is that as we get more and more data and more information out showing that, okay, that wasn't probably the best thing. You still see them, defending, their battle to the last stand. But like I said, I don't fault any of our colleagues for wanting to try to do something. I think you just put it perfectly right there. Is that it's that compulsion to do something. We don't want to be standing in the room helpless.
Right.
We don't want to be, when a patient is coding in the ICU, you don't stand around and just watch them code, trying to figure out in your head what to do. We're trained to move. We're trained to act, and it was fighting our very nature here when we didn't have anything to act with.
And all those unknowns that are flying around, and I mean, just fear, the the fear of, in the beginning, there were things that were being quoted like from in New York City and such about, there was 10% of the healthcare workforce was getting sick, and the mortality rate amongst healthcare workers was much higher than the general public and all this sort of stuff. So that led to a lot of fear amongst our colleagues, fear myself included. And you're going to struggle to make the right decisions when you're scared, and so that compounded it too. And so, yeah, you're exactly right. You can't blame people for trying to do the right thing. Everybody was acting in good faith to try to find the right answers. But I look back on it, and I worry about what did we do and what did we do wrong, and decisions that were made then that I would never make now. And it's just, it's been a really crazy thing to experience.
Definitely. And I feel like it did put, our core philosophies to the test, and still continues to do so. It also, in my mind, revives the role of the physician educator,
Yep.
physician teacher. And I think even that's been challenged in a year. When this first came out, physicians were the celebrities. I had patients thanking me for going to work every day, and I was going to work and doing telemedicine. I wasn't exposing myself or my staff. I mean, there weren't any patients to treat. I remember reaching out to our hospital administrator because we didn't even know what was going on in the hospital sometimes, and I remember reaching out to her and saying, I probably could brush off a textbook and run a vent if you need it. We were thinking,
Yeah.
do you need me there? I've got a nurse practitioner here that can handle what little we're seeing. Am I better useful in the hospital? And I think even it was you sent me some links of some critical care fellows that had put together some lectures
Yep.
to help train give us primary care doctors a refresher course on how to run a vent, because it's been a decade, and and to do that, and I found that interesting. I was glad to watch it, but I was scared. I mean, was I going to be more useful running a vent in the hospital cafeteria? Because
Yeah.
you were the overflow.
Yeah. We did that. We created videos and quick reference guides and stuff like that, because we thought we were going to have non-critical care folks working in the critical care environment, primary care docs that haven't been in the hospital in years, coming into the hospital to help take care of patients. We wanted to make sure that they had the tools right there ready so that they could get the answers quickly. And we had, basic vent videos that were less than 4 minutes long so that we could just quick reference type things, created these note templates that you would use in the electronic medical record that would kind of guide you through what the thought process should be for each organ system. And they were basically like single click. Is this okay? Yes. Is this okay? No. Is this okay? Yes. And that sort of thing. And if you would click no, then stuff would pop up of if if this isn't okay, then look at this and then look at this. And then, it went down like this decision tree. The bottom of the decision tree was ask an intensivist, because we had developed a tiered staffing model in case we were overrun. So where as an intensivist, I would be responsible for like 60 patients. And of those of those 60 patients, there's 4 other docs that are not intensivists taking care of those 60 patients at the bedside, and I'm running around kind of overviewing all of that and coordinating with those bedside docs. That's the plan that we had set up. Thankfully, we never had to use that.
Right.
We had to expand our staffing quite a bit, but we never had to go to that kind of emergency tiered staffing model because we were able to kind of keep things under control enough that we didn't have to take that kind of step.
Do you feel like the preventative measures that we pushed for as physicians, such as lockdowns and mask wearing and stuff, do you feel like that played a role in that we didn't get as overwhelmed as we possibly could?
Yeah. I mentioned earlier that Mercy, as they were going through that journey of trying to figure out what to do with the data and to try to put together some predictive analytics of what's going to happen in the community, they worked in coordination with the other healthcare systems in the St. Louis area, and everybody was kind of pooling their resources. And they came up with models that were strikingly accurate. And they developed those models to where they had the curve of what's the patient load going to look like, and they had worst case scenario, likely scenario, best case scenario, and the line that we actually tracked last spring was that best case scenario, and it was almost exactly on that best case scenario line. And so shutting everything down, the stay at home orders, all that sort of stuff, there's no question in my mind that prevented a real catastrophe and was effective. I think doing that saved a bunch of lives. I think one could argue, I would be open to the criticism that maybe it hung around a little longer than it needed to. I could be open to that criticism. I think that's fair.
Yeah.
I think one could argue that perhaps more could have been done this late fall into the early winter to try to keep things down a little bit more. But on the whole, I think we probably did about as well as we could, considering all the other factors that complicated the pandemic response.
Right. No, we saw the same thing where we felt like, at our worst or the most intense moments of COVID for us, which was not too long ago for us on the west side of the state, we felt like we kept it at our maximum capacity because yes, we were there. I mean, we were there, and if it kept accelerating, we were done for. But it peaked, and it peaked at our peak. I mean, we had moved every patient. We were fortunate. We have a large overflow building next to our hospital, and and when we knew it was getting towards the end of our capacity, we had moved every patient who didn't have COVID, except for the OB floor and the ped floor, out of the main hospital, and the entire hospital was nothing but COVID.
Yeah.
And you could scan the beds. There were no empty beds, so it was,
we had, all of our facilities, we figured out, we literally figured out the maximum, where's the maximum number of places that we can put human beings that need high flow oxygen BiPAP ventilators. Mm-hmm. We had that number, and we got close, but never got to that number, thankfully. Like, for example, the hospital where I work most now in Washington, Missouri, our third floor is our ICU and our step down. So there's 19 beds. And so if we fill those 19 beds, then we can go down to, it's basically it's kind of like our pre-op holding area. Mm-hmm. And at one time we had all 19 beds were full and that pre-op holding area was full. We literally had nowhere else to put another patient who needed a lot of oxygen. And we got to that maximum number, and we were kind of freaking out about, all right, what are we going to do when that next patient comes in? And we never crossed that threshold. It finally ticked back down to where it was still a heavy burden, but we could still manage it. So it never, thank God, it just never tipped over to that unmanageable burden.
Yeah. I tell everyone, you haven't heard too many news stories about the hospitals here in Kansas City and their treatment of COVID and that's a really good thing.
That's
You know, so it's,
yep.
you know,
Yeah, we never had to use that crisis standards of care policy.
yeah.
That was the thing. When we had there was a meeting of a bunch of Mercy leaders, and the group of us that had put together this crisis standard of care policy, and we were presenting it to all the different Mercy leaders. And I started the conversation, and I said, the first thing to realize is, if we have to use the crisis standard of care policy, then we have failed as a system to meet this challenge. And so we all have to view crisis standards of care as the absolute last resort. Because, you know, for those that aren't aware, the basic premise of crisis standards of care is, what we do in medicine is we do the most that we possibly can for every individual patient within their goals. When you move to crisis standards of care, you're no longer focused on the individual patient. You're trying to do the most good for society. And you're in a situation where the need outstrips the resources. And you're going to make decisions where you simply say, this person is not going to get critical care resources because the chances of survival are low. I don't think any physician wants to be in that position or wants to have that conversation with the family. And so we never wanted to get there, and thank God we never had to.
Definitely. Dr. Tannehill, not Dr. Tannehill, Dr. Dryden, I do see your hand raised. I'm working on getting myself co-host abilities here so we can let you talk. But we'll go from there. Yeah, you know, those were the scary things that we heard about in the news, about having to make decisions And I'm grateful we never had to make that. But you know, what was your experience, you know, with these crisis standards of care? You know, what was going through your mind as you were, you know, putting these together? And, you know, I'm sure you never thought about this ever happening when you were in medical school before.
No, I did study it in fellowship, because when I was a critical care fellow, it was during the H1N1 pandemic, and that was similarly busy, not nearly as bad, but it was still bad, and it was talked about. So I had studied it then, but yeah, medical school, it never came up. As we were going through it, there were basically two things. We have to make sure that we're doing everything that we possibly can to avoid having to use this. And if we use this, we have to do it right, because it would be reprehensible to make a mistake in executing that plan and not doing everything that we possibly could to be as organized and ethical and as objective as possible, and that sort of thing. It was pretty nerve-wracking.
You didn't want to end up being a news story.
That's right. That's exactly right.
Dr. Dryden, we have you unmuted. Do you have a question for Dr. Tannehill here?
Well, actually, I just wanted to kind of share a few things. First off, you know, I appreciate Dr. Tannehill's help he gave me personally in preparing for this. And my experiences as a small rural hospital without intensivists, without functional pulmonologists, and without the ability of other people to get their patients to tertiary care settings and sitting close to where there were others, there was times we were accepting these patients from ERs, from tertiary care centers, and from other areas. You know, we have a very small 8-bed ICU, and we were actually putting 2 patients to a room on ventilators. Our staff wasn't as experienced. Our respiratory therapists weren't as experienced. You know, the docs, we would try to keep up on what we should do. But I have a very strong feeling, because our mortality on ventilated patients was much worse than the averages I look at. And that was concerning to me. And I think a lot of it relates to our ability to have provided the care we needed to. And also my final question is there's a lot right now about oxygen toxicity. And were we actually damaging these patients? You know, I mean, we were keeping these people on high flow O2, high FiO2s very long term. And I'm convinced that some of them that were doing reasonably well, that would start getting better, and then their O2 needs would escalate and things, their chest x-rays would worsen. I'm fairly certain that that may have played a significant role. Just kind of would like to hear Dave's opinion on that.
Totally agree. I think we, in the beginning, one of the things we were like, we said, as soon as somebody gets to 4 to 6 liters of oxygen, they should be intubated, because the risk of getting healthcare workers sick and the risk of spreading the virus is so high, and these patients deteriorate so rapidly, they should just be intubated. And then the pendulum swung completely the other direction, where everybody said, nope, the ventilator's killing these patients. We need to do everything we can to keep them off the ventilator. And then I think we started to realize that, no, that's not right either, because when somebody is basically on BiPAP and can never come off, or they're on 100% on high flow oxygen for days and days and days on end, there's all kinds of bad stuff that can happen to them, not just the oxygen toxicity, but I remember getting a patient that had been outside the ICU, had been in our hospital for a while, was sick for a week before coming into the hospital. And by the time they came, they had been in the hospital 13 days. And I'm looking at the medical record and talking to the family. And this person basically had zero nutrition for 20 days. That has to have had an effect on this person and how sick they were. And so I think one of the biggest mistakes that we made is we should have treated this respiratory failure just like any other respiratory failure. When somebody, intubation is, there's nothing magical about intubation. It's a judgment call. And we abandoned our traditional judgment call for managing respiratory failure. And I kind of wonder if that was a mistake. I agree with you. I think the oxygen toxicities, there's something to that. And one of the things that we noticed in our own practice in my ICU, we kept seeing patients with barotrauma, pneumomediastinum, pneumothoraces, and that sort of thing. The practice had sort of been to get these people onto BiPAP, and they would end up on pretty high pressures of BiPAP, and they would have these huge tidal volumes on BiPAP and coughing and this, that, and the other thing. We switched to CPAP, and we switched to this more traditional decision to intubate, and I haven't seen that same kind of barotrauma that we were seeing before. I haven't seen the pneumomediastinum and all that kind of stuff since we've made that transition. I don't know if that's coincidence or if there really is something to that. But around the time that we decided to make this change, there were some things that were being published in the literature, case reports and case series of these pneumomediastinums and stuff. And this was that's what the conversation was amongst a lot of these authors. So I won't pretend to be, this magician who figured it all out on my own. This is all come from my reading. And I do think that there is something to that. And so when the Society of Critical Care Medicine released their guidelines, one of the things that was talked about amongst those authors was this concept of somebody who cannot come off of CPAP or BiPAP because of hypoxia. Don't let that go on for more than about 2 days, 3 days max, and then get them intubated. And a lot of us have shifted to that type of strategy. And I think that's on the whole probably a good thing.
I really like your candidness and willingness to talk about how, maybe some of our problems in the early stages of COVID was that we forgot some of the things that we learned in previous areas. And we already talked about how, it's with good intention from our physicians, us as physicians, we were trying our best. But it's great to be able to look back and see that. Hopefully not because there will be another pandemic in our lifetimes, but we can teach our next generation of physicians who one day will experience that, we have these tried and true methods, and we need to stick with them, even in the face of feeling like they might not be working. We need to, be really, really cautious before we do that and learn from that. I want to kind of shift our conversation in another direction in the 10 minutes we have left here, and talk about a subject that's very near and dear, I know, to your heart, particularly as your role as a member of the Board of Healing Arts, and your role as a past president of MAOPS, and that's physician burnout. Because this is not something that I think I've seen much reporting on at all, but it's something that I think both you and I can acknowledge, and I think everyone on this meeting, that this has been a huge issue. I just think it's like physician burnout's been in the past. We've buried it. It's been expected that this is a pandemic. We are the leaders of anything medical, and therefore we need to be immune to this. But maybe could you talk to me about maybe your own experiences of how you felt COVID affected you, and what maybe we could learn from that?
Yeah, I think there's no question that there's a whole lot of people in medicine that have overextended themselves, and have given more than they have maybe ever, and the burnout issue from this is real, and the damage that has been inflicted upon many of our colleagues is real. And so I think recognition that that's true is the first thing. And then two, I think being aware that some of our colleagues may be hurting and not asking them if they need help, but actually getting them help. Just as an example, one of our colleagues around here, everybody recognized that things aren't. This person's not in a good place, and so everybody kind of rallied together and said, "Let's get this person some time off." And there was really no, it was basically just, you're going to take a couple weeks off because you're taking it really hard. In the ICU in particular, the nursing staff took it really, really hard. The average stay in our ICU is like 3 days. And so, but these patients are in the ICU for 2 weeks, maybe longer. And you watch them go from, they're sick, but they're not terrible, to then being super, super sick, and then they die. And that's after a 3-week ICU stay. The nursing staff's not used to that. They're not used to the kind of relationship that you develop with a patient's family over a 3-week period of time, or the kind of relationship that you develop with a patient over a 3-week period of time. And there was a quote from one of our floor nurses, wasn't an ICU nurse. There was a quote from one of our floor nurses who said, "I'm not used to this much death." And I remember, I keep reminding myself of that quote because we've seen a lot of death in the last few months. I remember talking to one of my colleagues and saying, "I'm starting to wonder if maybe I suck at my job because everybody that I take care of dies." And in the ICU, we take care of dying people all the time. I've seen plenty of death in my career, but not to this magnitude, and not to this degree of the awful things that happen to these people. And I think the two best ways to address that is to, one, be honest about it, recognize that it's there, don't do the tough guy doctor thing, but actually talk about how you're hurting, talk about how it's been difficult, and then two, help each other out, and there have been times where, I've gone to the ICU charge nurse and I've said, "Hey, the nurse for the patient in bed 14 is really struggling. Let's see if maybe we can get her some time off," or something like that. I've never done that in my career ever, but I've done that a couple of times during the pandemic. And that's one of the real positives is the sense of camaraderie that I witnessed last spring amongst my colleagues in my healthcare system, and the sense of everybody just kind of rolled up their sleeves and said, "Let's get some work done here, and we're all going to do it together," was actually pretty inspiring. I mean, it was there was a few months there where that's the worst part of my career, but it's also been the best part of my career because of some of those types of things, because you realize what it is that we do for a living is a real gift. And we got to use that gift and realize that it's a gift. It sounds crazy, but it really was overall, a rewarding awful experience that I don't want to repeat.
Very well said. And I would agree. It's rewarding, but not something I'm ready to jump back into and do again
Right.
next year or this year. What kind of resources would you recommend for people who are feeling like they are burned out or have a colleague that are burned out? You know, what specific resources would you recommend for that?
Yeah. So first and foremost is just asking help from anyone and everyone, being open, honest, and transparent about what it is that you need. Obviously, for MAOPS members, we have our member assistance program that is there as a free resource as part of your membership. And that counseling, I can't emphasize enough how important that is. And most employers have an employee assistance program as well that you can reach out to. There are online resources that are available as well in lots of different places. But the biggest thing is to just encouraging ourselves and reminding ourselves to be open and to be honest and to just talk. That was one of the that's not really been part of my thing as part of my personality, but in the last few months, there have been a number of times where I've called somebody or texted somebody and just said, "Hey man, I just need 5 minutes. I need 10 minutes. I just need to vent, or I just need to unload this emotional burden." I think being honest about it in those terms, it's hard to do, but it's just really important.
And again, I would just emphasize the same thing. You know, seek some help if you feel like you need it. I remember when I was in internship, and this is probably because of past generations of interns, but we were required to, I think it was once a quarter, we had to meet in some kind of support group as interns. And it was a residency, like it wasn't even our residency, it was a accreditation standard that we had to do, at least just our intern year. And I remember that first meeting, we actually had one of our psychiatrists lead basically what I call the support group. And I think she just treated us like a AA meeting or something like that. You know, we were recovering from medicine, and it was so awkward the first time, you know, going around talking about, and they made us talk about our experiences as an intern. And it was so awkward talking about it because we weren't trained to do that in med school. I'd never seen, you know, physicians were tough, attendings were tough. You know, in my mind, they were still bulletproof, you know, but I agree with you. We have to learn to talk about what's going on. We have to accept that we're not bulletproof and use resources like the member assistance program.
Yep. And not only are you not bulletproof, but just simply the nature of being willing to serve and be a physician, you're automatically in a vulnerable position. You already are the type of person who's thinking of others more than yourself. And the chances of you hurting yourself for the sake of others is really, really high. Yeah, and we have to be honest about that with ourselves and with each other, and recognize that, I pretend to be this hard ass intensivist, but when you watch people die, that affects you. You know, when you watch people get really sick, that affects you, and you have to own that and recognize that could really hurt you, and you have to be treated as well.
Thank you. Again, you know, to anybody that's, you know, watching this or listening to this, you know, we've all been through a rough year, and if there is a need that you find where you are not loving medicine like you did before, or haven't done it for quite a long time, and you find that that's affecting you in your personal life or professional life, please reach out to what resources you have. And if you're a MAOPS member, please reach out to our member assistance program. This is a free resource that we provide to you so that you can access when you have it in times of need. It's a confidential way. It's not through your employer. It is something that you can reach out to and get that access. And like all things right now, it's done in a virtual manner. Therefore, you are able to get that resource. So in our last few minutes left, I don't see any chat questions. in our last few minutes left, your prediction of the future of COVID in our lives as physicians. And I know that this is pure speculation, but that's all we've had to deal with for the last year. Where do you think this is? Where do you think this is headed? Do you think this is the new annual flu, that will have flu than COVID? Do we think it's killed flu? I mean, who knows? Where do you think?
I don't think it's killed flu, but I do wonder if people are going to kind of study it and start to talk about how maybe the some aspect of social distancing, masking, hand sanitizer being ubiquitous and everywhere is going to be part of our life come flu season. I think COVID is going to be around for a while. I have zero confidence that we're going to get everyone vaccinated that needs to be vaccinated. I think we're going to have, amongst the physician population, it's only like 60 or 70%, or I'm sorry, healthcare worker population, it's only 60 or 70% that's been vaccinated. I don't see that changing in a dramatic way. I think there's people that are dug in on not getting vaccinated, and it's going to be really challenging to fix that. The public, vaccinating the public has been a bit of a mess, and it's been slow, but there is some gaining momentum. And I think if we really can get basically anybody who wants to get vaccinated in the next few months, then I think the end is near. But I think the burden of COVID is going to sort of stay right where it's at right now for a long time. I don't see us having a big spike again. I don't think that's very likely. But I think this kind of smoldering amount of COVID that we have right now is going to stick around for months and months. I don't think life back to normal like it was pre-COVID, we are a long ways away from that, because of those different things the different things are going to keep that steady burden of disease kind of hanging around. Long term, I do think that we're probably going to be looking at COVID vaccination and flu vaccination every fall. and this is not the last pandemic of our career.
That is probably true, but we can only hope. So, right. I wish it were so. I kind of agree with what you said. I think that we're going to have flu. I think we're going to have mask season every year. I think if we've proven anything in the primary care practices, it's this. I haven't had a positive strep throat in over a year now. I have treated 3 ear infections in the last year. And I'm in a rural family medicine clinic that sees lots of kids, and I should say saw lots of kids. I don't see that many kids anymore. They're not sick. I get an occasional sports physical, but for illness, I mean, it's just not happening. We've proven that social distancing and these things, we had an acceptable level of illness in the population, and so it'll be interesting to see if we go back to that acceptable level of illness. I sure hope for my income's sake that we do. And I know that sounds pretty mean for me as a physician, but I built part of my practice on that acceptable level of illness. And we're going to have to find some new ways to make money if we don't get back there. But that being said, I am very happy for the population and how healthy it has been. And I will be honest, I have been the most healthy in my life this last year. I mean, I normally get 4 to 5 colds a year. I pick them up from patients or my own children, and haven't picked up any this year. I mean, it's been a year since I've had a cold, which is great, and wonderful. So I want to thank everybody, especially you, Dr. Tannehill, for being with us tonight and sharing. I think most people would agree that this has been therapeutic for us to listen to a physician like yourself describe your experiences, because we've gone through similar experiences, and I know how therapeutic it is just to hear that and to know, hey, we're not alone. If I've ever found a good cure for my own experiences with burnout, it's learning that I'm not alone in what I'm doing, and that I'm not the only person that's experiencing this. And that's always been the most therapeutic thing for me, is just talking to another physician and realizing, hey, they're burned out too. And then, oh, well, then I'm not alone. And it's suddenly like it's better. It's amazing how humans are. And if anything would tell you that, the scary thing about lockdowns is that we have created that isolation, and we see that in our patients. And so while they've been needed, we need to figure out how to make it so that they don't feel alone as well, and receive the treatments that they need. So thank you very much. Thank you, everybody who participated. I would put one plug out for our virtual osteopathic conference that is coming out you know, please go to mayops.org. Look at our virtual osteopathic conference that's coming, our VOC. You can sign up. If you think just 1 hour is great, you can get, we're going to have over 48 credit hours available for you in varying tracks that you can attend. So please take the opportunity. I think are you speaking there at all, or is this we finally give you a year off?
No, we're talking about crisis standards of care.
There we go.
Yeah.
And also you are, you know, one of the co-directors of the educational program too. So all right, yeah. I don't know. I'm sorry, that's Jeff and them this year. But yes, we've got Dr. Tannehill coming back for crisis standards of care. That actually will be very interesting. So great.
Thank you very much.
Thank you, everybody. Everybody have a wonderful evening.